So my only conflict is not relevant to this discussion. And the moment that I mention aqueous humor dynamics, your eyes are going to glaze over, and so back to you. But one takeaway here that's kind of simple is that aqueous production drops significantly in the evening. And so one pearl I'd recommend for patients who have advanced disease that are high risk with, say, split fixation defects, a lot of time we're dosing our BID drops, our true aqueous suppressants, timolol, dorzolamide, brimonidine. We're doing that second dose in the evening. Often they're already on a prostaglandin. It's just easier. There's twice a day. You know, when they're doing drops, they're not having to think about a third time in the middle of the day. But if you've got a high-risk patient, you're going to get more effect from suppressing aqueous production by doing that second dose in the afternoon. So those patients, I'll actually counsel the ideal regimen would be to do, you know, morning, afternoon, and then at nighttime, you're separately doing your uveoscleral and, you know, prostaglandin, nutarsadil. So that's one pearl, and that's just for, again, high-risk patients that are okay doing that third time during the day. And again, all of this is just food for thought. So in the MIGS space, I do a lot of MIGS, or at least four different procedures or so. But I would recommend caution with patients who have split fixation defects or really high-risk glaucoma with regard to incisional MIGS, where you've got a risk of hyphema. We are all highly influenced by our outcomes and our particular patient scenarios. I had a patient with where I did an Omni, and they had a pretty decent hyphema. This was early in practice, and they didn't snuff, but they took a hit, and so I would say caution with, you know, the MIG space, and I'll keep Zen in a separate category, but I would describe them as minimally invasive, moderately effective procedures. And then also, not all patients that come to you on drops need a MIGS procedure. So remember that cataract surgery does lower pressure in and of itself, and if you get some angle narrowing, you get even more lowering of the eye pressure. So, you know, the Oates data provides this. I think it was Mansberger who looked back at that, and the amount that you're going to drop the pressure with cataract surgery alone is proportional to where you're starting from. So you get more of a drop with higher pre-op pressures. But for example, your patient who's got a Tmax of, say, low 20s or mid 20s, who's got a normal pachymetry and ocular hypertension patient, that patient doesn't necessarily have to be on that prostaglandin or get a MIGS procedure. They're probably going to drop upper teens right after cataract surgery. So I will include a discussion when I'm saying I want you to be aware that MIGS devices are out there. I'll write discussed but defer MIGS. I want them to be aware that it's there, but not every patient needs it. So let's see. We all know, you know, you get a lot of false positives with large nerves, so remember optic nerve size. I know everybody knows this. You get false positives with physiologic cupping, but it is easy to miss glaucoma in a small nerve. So remember to consider optic nerve size. You can use various, depending on the lens that you're using, you know, ratios to convert what the exact size is. But this image is showing, you know, pretty small optic nerve, or pretty small cup to disc ratio, and there's a disc hemorrhage in that middle picture, and then a little notch that you get as that progresses. So you may have a cup that's 0.3, 0.35 with glaucoma, and it's easy to miss that in a small nerve. So keep optic nerve size. This is an interesting one. So I'm 5 years into practice, but I'm struggling with wait times. There's not enough of us out there that do surgical glaucoma management. And I've kind of settled on just realizing that if you combine the unpredictable, high-risk complexity of surgical glaucoma care with ethical care and not being, you know, you're not going to cut corners on things, you're going to take time with patients when you've got to have that unexpected heavy discussion, you inevitably land with wait times. And I started using some videos very cautiously. This might be a controversial topic, but I found myself giving some spiels about what to expect from me as a doctor and what to expect for my clinic and why the wait times can be variable. So I made at first a video that just gives an introduction to what I'm like as a doctor. I tell patients I tend to be pretty direct about things because that's how I would want it. I will always respect their decision to do anything that they want to, and I'm committed to treating them like family. And then I kind of go into what to expect from a surgical glaucoma clinic and why wait times might be longer. I've had, and I say I approach this cautiously because I never wanted a patient to feel like I was trying to move them through the clinic or decrease the quality time that I would have with them. And often they're getting that video, for example, before they come into the clinic. But I have had an unexpected level of incredibly positive feedback from my patients about this. Some patients who are high-functioning HR people who say, this is really great. And then, and it kind of surprised me. So I'd have a cataract video that's kind of a general overview. I have an IOL options video that for patients when they're going home after a cataract discussion educates them about different types of lens options because I can't counsel them yet because I haven't had their biometry, kind of educates them. And I have a next day post-op video. It's a relatively short number of videos, but I've found them incredibly helpful. I always, if I'm using one in clinic, will say, if you have any questions after this, I want to come back into the room afterwards and make sure that we've answered all of your questions today. But again, they're often being used before or after clinic time. And the point there is you can use them effectively and I've had really good patient feedback. Like I said, I've been doing this for 5 years, and one day I started seeing faces in my testing. I don't know how many people have seen the face? I'm serious. Have you guys noticed this before? It just seriously jumped out at me one day. I'm like, that is smiling at me. But and if you haven't noticed it, I mean, now you're never going to not see it. You're going to see it everywhere. So sorry about that. But we don't want glaucoma to be happy. We want it to be frustrated. That one's kind of creepy. So that's an Optos image that, gosh, this would be a Halloween thing. But anyways, somehow ended up with multiple slides there. The one that didn't make it in here, and I think this is probably the most important one, is Pearl is, and all of you know this, you've got more years, many of you do than I do, but check your pride. We know to do that when you're going into the operating room, and I've started to develop this habit of actually touching the door frame. And there's something, with routines and actually physically doing something in action that I think is really helpful. So I started kind of tapping the door when I walk into the OR. If I ever catch myself in my mind going to and I've caught my brain doing this, I'm pretty good at this, and it's danger, red flag, and if I catch any sort of thought like that in the operating room, I will start praying for the patient by name and their family, because if you've got time to be thinking about other things while you're doing the cataract surgery, you can be praying for that patient. But I would say the Pearl is, I really find tapping the door frame really meaningful. And so that then applies to the clinic. And most importantly, and I don't do it enough now, and I'm saying this for myself, I need to be tapping the door frame at home, really every single room that you enter. So check your pride is probably my biggest Pearl. And and with that, so I've got a picture on the left is my daughter having the quintessential s'mores experience, which I like that. My son loves to fish, and then that's the Smoky Mountains in the middle, which we've recently discovered is just absolutely gorgeous. So I will say as well, Greenville is great. This is a small plug. Everywhere needs a glaucoma specialist, but there's even 4 of us in this area, and I'm overwhelmed and in triage mode. So if you know like-minded people who would be interested in servicing that need in this area, send them our way. I would love to talk to you. It's a great field. And with that, we're going to hold on questions for right now because Doug and I are doing this together. So my partner, Doug Stokes, has already been introduced. He is amazing, anchor, as was said, and very, very wise. This has been a particularly unique dynamic that as a young doc coming in, I've had Doug to lean on for the complex stuff as he transitioned out of surgery when I came in. So I've been very grateful for that context. So thank you.
All right. Thanks, Peter. Good morning. I do have one disclosure. It is not relevant to what we'll be talking about this morning. Most of you know that J. Lawton Smith was born in Greenville and grew up here. So before we launch into glaucoma pearls, I thought it would be most appropriate to give us 3 pearls from Dr. Smith, much more important than any glaucoma topic we'll be covering today. The Bible is true, God is real, and Jesus Christ is alive and is coming again. Dr. Smith also mentioned these three priorities in this order: God, family, profession. The glaucoma preferred practice pattern is voluminous. We won't spend much time on this, but I'm going to hit a few high points here. We all know from academy data that gonioscopy is vastly underperformed, and it is critical for making the initial diagnosis. Be sure you're performing gonioscopy initially when you see a glaucoma patient, then as needed appropriately in follow-up visits. Pressure measurement, preferably by Goldman applanation tonometry. This is the standard of care for checking pressure. We're all busy. We all have technicians checking pressure. I do too. I check most of my pressures. My technicians have been trained. They do Goldman pressures. If I get an unexpected pressure, I will check behind them, but I would encourage you to be using applanation tonometry in glaucoma patients. Diagnostic testing, central corneal thickness, visual field examination, and optic nerve head evaluation and imaging. Even though quantitative imaging technology is approved as an adjunct, the clinician should include all parametric and other structural information when formulating patient management decisions. Patients don't like visual fields. We all know that. They don't mind OCTs. They take a couple of minutes. They don't mind that. Don't neglect visual fields. They're critical in managing glaucoma patients. SLT is being performed a lot more commonly after the light trial. I will mention one thing. The preferred practice pattern recommends an IOP check after the procedure within 30 minutes to 2 hours. In my practice, IOP spikes after SLT are very uncommon, but they can happen, and the standard of care is to check the pressure after the procedure. This is a very busy slide, but these are recommended maximum follow-up intervals in glaucoma patients. If we focus on the horizontal rows, the top 2 rows are where we want to be. These are stable glaucoma patients. Target pressure achieved, no progression. Recommended maximum follow-up intervals 6 to 12 months. In my practice, in most stable glaucoma patients, they come back every 4 to 6 months. Third row, pressure good, but progression of damage. These patients need to have their target pressure reset and their therapy changed. Maximum follow-up interval 1 to 2 months. Fourth row, pressure too high, progression of damage. They need their therapy changed. Maximum follow-up interval 1 to 2 months. We're all busy. Our schedules are full. There's no room for follow-up patients. Don't go out too long on these patients when you're changing their therapy when they're worsening. 1 to 2 months maximum. Last row, pressure too high but no progression. This is a quandary. We all have patients like this. Pressure slightly high with no progression. You can watch them. There may be reasons for not changing their therapy. The maximum follow-up interval on these people is 3 to 6 months. But be sure you can infer, or is written in your chart, the reason you're not changing their therapy if there's a good reason for not changing their therapy. Don't neglect visual field evaluation. Visual field evaluation should be performed at least yearly. We're all familiar with the ICD-10 glaucoma staging system. Characteristic optic nerve abnormalities plus a normal field in mild glaucoma. Hemifield, loss in one hemifield in moderate glaucoma, but not within 5 degrees. And both hemifields severe, or one hemifield within 5 degrees of fixation. I would submit to you this is a coding system. It might not be the best system clinically for following and managing patients. Mild glaucoma on the field, this patient could have significant or even profound disc damage. Don't get too reassured by a normal field. Look at the disc as well. Moderate glaucoma, an arcuate defect in one hemifield. I think we would all agree that this is severe glaucoma, but so is this. This is a paracentral defect in one hemifield, but it is at fixation. So here is severe glaucoma, and here is moderate glaucoma. Not what you would expect. This, again, is the ICD-10 classification. May not be the best system for taking care of patients. Keep that in mind when you're writing a code in your chart. MIGS. You can go to any ophthalmology meeting and hear a talk on MIGS. We won't be covering that today. We're going to take a minute to talk about maximally invasive glaucoma surgery. That is either a trabeculectomy with mitomycin or a tube shunt, most commonly in this country a Barvelt implant or an Ahmed valve. And I'm just going to present a couple cases of a couple of patients I've taken care of over the years. First one is a 37-year-old white female with pigmentary glaucoma, referred to me in my first week of practice a little over 30 years ago. She had lost vision in the right eye, complaining of losing vision in the left eye, multiple ALT procedures, on maximum medications at the time. Hand motions, right eye, 20/40 left eye, an APD in the right eye. Reasonable pressures, but again, she's getting worse with pressures of 16, 17. Characteristic slit lamp features of pigmentary glaucoma, open angles on gonioscopy, significant disc cupping, and her field in the better left eye, a superior arcuate scotoma with extensive nasal constriction and depression. Sorry, I don't have the field to show you. I was unable to retrieve that. It was so long ago. She underwent a trabeculectomy with intraoperative mitomycin C. She did well. She lived in another part of the state, resumed follow-up with her local ophthalmologist there, but she returned to see me 30 years later when she moved back to Greenville. She had had cataract surgery in the left eye at that point. She maintained 20/40 vision in the left eye, pressure in the hand motion right eye 26 on more modern maximum medical therapy, pressure of 13 in the left eye on no medications, a low diffuse filtering bleb with the posterior chamber lens. Her discs were unchanged. We did a corneal thickness at that point, which was fairly average. This is her OCT from the last year, and this is her most recent visual field. A superior arcuate scotoma with extensive nasal constriction, very similar to the way it was described 30 years ago. Second case is a 68-year-old African-American female with chronic iritis, which had worsened after cataract surgery, uncomplicated cataract surgery, and her pressure went up as well. Past medical history remarkable for asthma. She was on predforte, brimonidine, and dorzolamide. Good visual acuity in both eyes, pressures of 32 and 34, very thin corneas, chronic AC reaction on slit lamp exam, open angles, pretty significant cupping in both eyes, and a mild epiretinal membrane. And these were her OCTs and visual fields on presentation, pretty good looking visual fields in her situation. She was referred to rheumatology for a workup. They found osteoarthritis, but no other systemic inflammatory syndromes. I did make several changes in her medication. I tried starting a prostaglandin, which is not my favorite with inflammation, but I tried that anyway. It did not improve her pressure. Neither did adjustments in her steroids, or I even stopped her steroid and tried a non-steroidal. Her pressure remained high with all of those things. She had a 350 square millimeter Barvelt implant placed in each eye approximately 3 months apart. Her post-op course was unremarkable, and this was about 7 years ago. 7 years later, she has maintained good vision. Her pressures run 10 to 14 on brimonidine, and we're able to treat her with Durezol now, and her pressures are still controlled. No anterior chamber inflammation on her slit lamp exam. Serial OCT testing has not changed, and neither have her fields, and so she has remained stable. So the question arises, if there's still an indication for these procedures in 2024, will there be ophthalmologists trained to do these things? So this is a study last year from Ophthalmology Glaucoma that looked at current glaucoma fellows being trained. And an average glaucoma fellow performs between 20 and 30 trabeculectomies every year and between 45 and 50 tube shunts every year. So their conclusion is, yes, glaucoma fellows are still being trained to do these procedures right now. Hopefully that will still be the case in the future. So we started with some pearls from J. Lawton Smith of Greenville. We're going to end with these pearls from Simon Peter of Galilee. Grow in grace and knowledge of our Lord and Savior, Jesus Christ. We're sitting here in this room this morning to enhance our knowledge of ophthalmology, to take better care of our patients, and that is important. It is critically important that we continue to grow in grace as well. Do not neglect that. With that, I'll ask Peter to come back up, and if there are any questions for either or both of us, we'll try to tackle those.
I know you didn't talk about this, but with patients who have glaucoma and receive intravitreal injections, I'm a retina specialist. What's your advice to retina specialists and to general ophthalmologists to care for these patients? Because oftentimes over time, especially with chronic injections of that cyclical IOP rise of going from, say, the normal IOP to 40 or 50, and now with Syfovre and Izervay, you're putting in 0.1 ml into the eye, and now you get pressure rises of 70 or 80 right after the injection. So concern is for basically inducing and trying to keep glaucoma from progressing in these patients.
Yeah, I think that emphasizes a critical point of checking the pressures at the day of the injection as well. So knowing where that starting point is, because the same way we're following patients and pressures can fluctuate quite a bit, that should be informing a decision of whether or not to inject given where they are that day. It's a tricky one. It's a risk-benefit situation. And my patients that I know are receiving serial injections, that's going to impact where I want their pressures to be, so I may target them a little bit lower on average. So yeah, you're right. I mean, I remember still in training when right after an injection, watching the pressure right afterwards, I kind of, out of interest, checked the pressure right after and kind of followed it for several minutes, and it spikes quite high. So that's a factor that has to be considered, especially for normal tension patients or really high complexity fragile eyes. But at the end of the day, you're in that between a rock and a hard place with, the wet AMD is going to knock out the vision or whatever it is versus, taking a hit and you have to walk that balance. But yeah, I'd say that emphasizes check-in pressure the day of the injection and letting that inform whether the injection happens that day. And then on the glaucoma side, us trying to target a little bit lower on average for patients we know are getting serial injections.
I'm a cornea guy, but I do a lot of glaucoma stuff in Guam. We see a lot of glaucoma patients, and I was curious if you guys could comment. At the last academy, I went to Glaucoma Day, and I've started doing ganglion cell layer analyses on all of my patients, and 10-2s on a significant number. And we also converted over to the virtual field, which is it has an eye tracker, speaks to the patient in 20 languages, and to me, it's about 10 times better in terms of reliability, and the correlation with the Humphrey is very, very close. I was wondering if you could comment on those things for our group here.
Sure. I'm a big fan of 10-2 field, so any of my patients that have split fixation defects, I'm routinely checking. I don't necessarily make them do a 10-2 every year because I'm often checking a 24-2 on those patients as well, but I like having more data about exactly where the borders of that scotoma are, so I'm a fan of 10-2s. The ganglion cell analysis, I have not incorporated that into my practice at this time in a meaningful way, but I think that's a really great question. Sorry, I think do you need to clarify?
Yeah, I think it's profound to see the correlation between the 10-2 visual field defect and the ganglion cell layer analysis. And sometimes it's just like precise. Sometimes it's not. And then I've also found that with the virtual field, sometimes you won't show a visual field defect in the pattern deviation, but in the total deviation, you'll have a defect that will correlate to the ganglion cell layer thinning. So I'm a total fan of the ganglion cell layer analysis.
And Dr. Azrani, I believe, at Duke has done some really incredible presentations on that. So that is a great area. There's a whole other set of artifacts you've got to tease out as well, and that's part of when I was in training, part of teasing that out. But I think that's a great point. I am very interested in the virtual perimeters. We haven't pulled the trigger on that yet. I've kind of wanted to try that for some patients who have positioning issues. The big question is the validity and really looking at the data on comparing to Humphreys, and so that's been on my to-do list in the last year to really compare the data on that.
You have a reliable test. The mean deviations almost match exactly with the Humphreys, so you have no problem with regression analysis comparing yours to the company.
Yeah, no, that's a great question.
Yeah. Anything we can do to make fields more patient-friendly and less onerous would be a great thing.
Quick advice. On a 72-year-old patient, pressures of 21 in each eye, and a little hemorrhage on one of the discs, has cataracts in both eyes. Should she have a MIGS put in? No field defects.
So you're saying a pressure of 21 with a disc hemorrhage in one of the eyes?
Correct.
So one big question is whether the disc hemorrhage is related to glaucoma or not. So I think there's a lot of variables. I mean, you have to rule out hemorrhagic PVD, of course, and all these other things. But if pressure's 21, again, that's borderline on whether they're normal tension. I think the complexity that goes into making those decisions, obviously, is probably the 8 things I'm juggling in my head, including what the nerve looks like on exam. So that would be a nuanced.
I'm glad you mentioned the 0.3 cupping, bilateral, symmetric, no notches.
So if we're talking someone who doesn't have glaucoma, just has an isolated disc hemorrhage that we're not thinking is a PVD related, and they're starting at 21, let's say they've got a normal pachymetry, I'm not going to do a MIGS on that patient. I'll treat them, and I'll have a discussion with them about it, but I'll see where their pressure is going to come down. I mean, they haven't had SLT yet, I'm assuming. I'm going to follow that patient. I mean, a disc hemorrhage is an independent risk factor for glaucoma progression. I like to check fundus images comparing beta zone progression. So that's a little pearl I'd mention. If you see progression of beta zone atrophy, that gets my attention too. But a lot of nuance there.
And if they're having cataract surgery, then you would just do the cataract surgery and not put a MIGS in, is what you're saying?
Correct. I would not take a normal pachymetry, Tmax of 21, totally healthy nerves. I would not do a MIGS procedure on that patient.
Thank you.
All right, thanks.